thanks, Mark, for setting the stage for this talk. I guess my job in discussing metastasis of the prostate cancer is quite easy now. Yeah, so just from the start of the screen, the picture there, that's two things I think about. One is me thinking about this vast topic and how me just in front of it. And the other way is actually oligometastatic prostate cancer, a real big lion in the long run. So that's what I wanted to bring out from putting up this slide. I'm trying to see if I can move to the next. So we're going to be discussing definitions in oligometastatic prostate cancer, biomodels, role of imaging, and management options. I've tried to summarize a lot of these things, and a lot of these sub-agendas could become a talk on their own. There's just so much of information around. So do bear with me. Some of the discussions I have purposely omitted so that I can get to the meat of the matter. So the definition of oligometastasis is from 1995, which was coined by these two gentlemen. And it was where they sort of described an intermediate state of cancer spread, where it's between the localized disease and the widely metastatic disease. And the concept of introducing this state is, could we possibly achieve cure rather than have palliative direction to therapy? And that was where the whole idea of oligometastasis actually started. But it's not as easy as that. And the issues is that the definitions are quite varied across major trial groups, and people don't seem to yet sort of agree on one sort of standard definition. There are people who would have visceral disease, others would have nodal disease, then bone metastasis. And in the current era, there's even more complexity based on what imaging modality are you using to figure out where the metastasis is. You cannot obviously say that conventional imaging, that CT scan and bone scan, has similar pickup rates to the functional imaging, that's the PET-CTs. So what imaging are you using, and what's your definition? That's quite varied, and this creates a big pool of varied data, varied ideas, and a lot of confusion personally. And then to mix the whole situation up, you've got what clinical setting are you talking about when you're talking oligometastatic cancer? And you can basically divide this into three. There's the primary, the de novo oligometastatic, where the patient's prostate cancer has not been treated, and now they present with oligometastasis at the onset. There's oligorecurrent prostate cancer. In this group of patients, prostate cancer has been addressed and there's treatment to that. And now there's progression from biochemical recurrence and workup for that, showing there's oligometastasis. And then the last group of patients is the oligoprogressive or oligopersistent prostate cancer. This is usually in the setting of castrate-resistant prostate cancer. And these are very, very different entities and very different biologies of metastasis and biologies of cancer. And basically trying to get through to them, talking about oligometastatic cancer becomes even a bit more confusing through this. So I'll say a few things about biomodels. I think Mark has done a great job discussing the biology of prostate cancer this morning. But what I wanted to bring to light was the role of primary tumors. So on your left, you have this diagram, which is an older edition, and it's basically simplified where the primary tumor had a role, but the metastases also have a role. The newer version, which is on your right, actually shows how much the primary tumor plays in the pre-metastatic niche. How much does the primary tumor actually contribute to the whole environment of metastasis? And it induces inflammation, immunosuppression, organotropism, lymphogenesis, angiogenesis, and reprogramming. And therefore, from this, if you think about it, if you got active control of the primary tumor, you basically kill the whole pre-metastatic niche. And that's the idea behind dealing with the primary cancer in an oligometastatic setup. The other idea is that what is prostate cancer, and especially metastatic prostate cancer? There's no real agreement whether it's actually a monoclonal entity or is it polyclonal. And when you talk about polyclones, there's the idea of fused clones, so where they're spatially, clones which are spatially near to each other might actually fuse and have another clone of their own. And it is thought in some schools that usually the metastasis happens from one set of clones, so it's a monoclonal entity, which then subdivides into subclones, and these subclones have the ability to generate more subclones. And then we also have to remember the idea of a positive surgical margin, which might also end up having a metastatic aspect to it. This was an interesting study. It's a small study. It had only 6 patients, but they were basically looking at the phylogenetic analysis of metastasis. And what they found was quite intriguing. One is that if you looked at the lesion in the prostate and they categorized that to extraprostatic lesions and intraprostatic lesions, what they found was that the extraprostatic lesions actually had no bone metastasis, whereas the intraprostatic lesions had more bony metastasis. And when they sub-analyzed these patients, the phylogenetics of lymph node metastasis were completely different from bone metastasis. And what this sort of brings to light is the idea that we all think that, metastasis is a progressive disease where you'll have mets to the lymph nodes and then mets to the bone. That might not actually be true. You might have several other mets going on, and it might not necessarily mean that it's progressive from lymph node to bone. What about the mutational landscape of metastasis? So this is interesting. One, the green line is where we're talking about, the oligometastasis, and the red is the biochemical recurrence. And the purple, what I would like to draw your attention is to de novo. You can see from the outset that the overall survival for oligometastatic disease is actually comparable to biochemical recurrence, whereas if you compare de novo metastasis, they've already got poor prognosis from the outset. And some of the genes are actually sort of implicated in this is the P53, the WNT, the BRCA, the ATM genes. Those are genes known to have more aggressive form of disease. And so in the future, can we add to the definition of oligometastasis using genetic variations? And that's also a sort of an idea that's coming up, but it's not quite in the open yet. Just a quick word on role of imaging. So this is an evolving area, and there's a lot of new data around this sort of specific subtopic. But I just wanted to keep it simple. You've got multiple types of imaging modalities. You've got your conventional, that's your computed tomography, that's CT scan, and the bone scintigraphy. You can also do magnetic resonance imaging, and the latest is the functional imaging, which is the PET-CTs. So what do the guidelines tell us? In the primary setting, you can perform cross-sectional imaging and a bone scan in high-risk localized disease, and you can also do a PSMA PET. This is just basically to pick up if there's any metastasis. If you got persistent PSA after dealing with your prostate cancer, then it depends. If you've got a PSA of more than 0.2 and the results will influence your treatment decisions, then you're advised to go ahead with a PSMA PET. You can see that we've done away with the conventional imaging because it's not going to pick up much at that stage. In the setting of biochemical recurrence, after radical prostatectomy, based on your level of PSA, if it's more than 0.2, you can do a PSMA PET, and if it's more than 1, then there's a better pickup rate with the choline or the fluciclovin PET CTs. In the case of recurrence, again, the standard is PSMA PET. I'm not going to say much about the data and the details around it. That's a talk on its own. But we're going to jump into the rationale for treatment. So why would we want to treat oligometastatic prostate cancer? One is to break the chain. So you have to have aggressive local treatment, and we saw that from the pre-metastatic niche. It reduces the shedding of cancer cells. Surgical removal of primary tumor reverses tumor-induced immunosuppression. When you treat systematically, potential lethal cancer persists in the primary tumor and can contribute to progression. So you need to treat your primary tumor. And when you treat the primary tumor, you break down the crosstalk between the microenvironment, metastatic niche, and the primary tumor. And therefore, the control on the microenvironment metastatic niche is gone. And this lends the metastatic sort of lesions a bit more vulnerable to treatment. And then the next part of wanting to treat, or rationale behind treating, is actually to seek and destroy. And for this, you will need very accurate detection studies, and you need to detect them early so that you can provide an early metastasis-directed treatment, which will be in line with providing cure for the disease. This is a slide that I picked up from the EAU 2022. It's basically showing the management landscape of prostate cancer in 2022. And I think where our sort of management, if we were going to start talking about oligometastatic, would fit in would be where the red dots are. So you'd have your de novo metastatic prostate cancer, oligometastatic, you'd have your oligorecurrent prostate cancer, and then in the castrate-resistant prostate cancer. So this is just basically putting the whole picture, perspective into the picture. So we'll now give some time on the different aspects of the metastatic, and I would like to start with the de novo oligometastatic hormone-sensitive prostate cancer. What's the rationale for the radiotherapy? So according to the EAU, you should offer ADT with radiotherapy to patients who present with de novo metastatic disease. And this is according to the charted criteria that we have. To not offer ADT combined with local treatment for high volume disease. This is again coming from the charted trial. When you talk of oligometastatic prostate cancer, there are two big studies that come to mind. It's the STAMPEDE and the HORROR. And the article by Burdett in 2019 seems to summarize this very well, where they sort of classify. So this is a post hoc analysis of the HORROR trial. The HORROR trial initially did not show any benefit, but they did not subclassify into the lesion numbers. If you now subclassify into less than 5 or more than 5 metastases, and you check the overall survival, the progression-free survival, and the failure-free survival, it actually, from the forest plots, you can see that there's actually benefit in giving radiotherapy and ADT to patients who've got less than 5. So that's where the less than 5 is for the HORROR and the STAMPEDE. Again, for the HORROR, for the STAMPEDE for progression-free, and then failure-free for STAMPEDE and for HORROR. What's about the idea of giving comprehensive RT? So this is also what is called the metastasis-directed therapy. Currently, according to the EAU, do not offer metastasis-directed therapy unless you're within a clinical trial or a well-designed prospective cohort study. The level of evidence here is lacking. There's no much level 1 evidence, but there is some good retrospective studies. Some of the studies, one of them I came across was this by Imber. It had 47 men who had de novo oligometastatic prostate cancer. And what they did was prostate-directed radiotherapy, oligometastasis radiotherapy, and then they gave the patients ADT. And they had 70% undetectable PSA after testosterone recovery. A lot of new information is expected in the pipeline from the STAMPEDE 2 trial, the PEACE trial, and the PLATINUM trial, which are still eagerly awaited in this sort of scenario. If we talk about surgery, do we have a role of surgery in the de novo oligometastatic prostate cancer setting? The guidelines strongly recommend against offering surgery to M1. But from the slide from EAU again, I sort of want to debate about the pros and cons. So what would be the implications of offering surgery? One, you can get an accurate assessment of the real extent of nodal invasion, not just by, sort of having ideas on imaging. You literally have histology. You maximize local control in bulky disease, and your multimodal approach is improved because now you can also give radiotherapy after tumor debulking. And there's a tailored approach based on your pathological report and the post-op PSA. The problems with this would be that there's short and long-term side effects of offering multimodal approach. Not all patients would be beneficial from the surgery, and that there is no abscopal effect. So the abscopal effect is that when you treat the primary, sometimes the metastasis would regress, which doesn't really happen with surgery. With radiotherapy, you can induce immune system, and that you can have. And then the radiotherapy, well, oncologists would have this weak argument that you guys just bring the patients to the cancer clinic for RT anyways afterwards. So I'm not putting on surgery. We would look at a few sort of scenarios. And the first one is the clinical N1 disease. You can offer, this is what would fall within our sort of pelvic lymph node dissection bracket. I found this article, or this flow diagram quite interesting, where they were saying that you would have to risk stratify your patients better to have better outcomes. And this could be done based on your Gleason grade, site of the nodes, and the number of the nodes. And obviously, if you think about a higher Gleason grade, which is in the retroperitoneum, and the higher number of nodes, you'd have higher chances of having less chances of having recurrence-free survival, sorry. And if you use the opposite with low Gleason scale, less nodes, less in the pelvis, then you'd have a higher chance of ATL clinical recurrence-free survival. What about the CM1A and M1B? M1A being extrapelvic nodal disease and M1B being the bone metastasis. So there wasn't much randomized controls trials in here. And I think the first control trial was actually the trombone study, but it wasn't. It was more of a feasibility study where they showed that you could do radical prostatectomy in patients who had bone metastasis. But this came out last year, an article from China, which was actually a phase 2 randomized control trial. And they had sort of grouped the patients into two arms, ADT only, and then ADT with radical local therapy. And pelvic lymph node dissection was done as an optional component. So they had 200 men, of which one arm had 100 each. Important to note is that in the trial arm, 85 patients received radical prostatectomy and only 11 had radiotherapy to that. So it did end up showing that radical local therapy plus ADT increases the recurrence-free survival, overall survival, and the PSA progression-free survival rates. And the procedure was actually well tolerated. This is narrative from very known cancer surgeons, so prostate cancer in the field of prostate cancer. And their iteration in the same sort of publication was that radical prostatectomy should no longer be considered investigational. There is effective alternative to radiation therapy, and we need to inform our patients that radiotherapy has robust level of evidence, but that does not mean that radical prostatectomy is not as good. And we do have now observational studies and this prospective randomized control study, which confirmed the benefit of doing a radical prostatectomy. Of note was they would give the patients ADT and then repeat imaging, and how they would decide was after the ADT if they would offer radical prostatectomy to this patient. So it's not at the onset that they offered radical prostatectomy to all their patients. They offered ADT. If there was progression or reduction in the size of the tumor, then they would go ahead and offer a radical prostatectomy to them. We move on to the oligorecurrent metastatic hormone-sensitive prostate cancer. This is where the primary has already been treated. And I would like to just start with this graph here, which sort of gives an idea of why we would want to be treating aggressively the oligometastases. And if you look at the two graphs, the one depicted in green is what would be your standard of care without dealing with metastasis. And you can see that it projects sort of higher PSA levels and a faster time to castrate resistance. Whereas if you ended up doing metastasis-directed therapy, your PSA levels would drop a bit more and you'd have a bit longer before you became castrate resistant. And this is actually what the idea behind metastasis-directed therapy in the oligorecurrent setting is all about. There's a lot of trials in this, and I've tried to summarize. The part that struck me the most was these are not big trials. These are patients, maximum of like 30 or 60 to the max. So you've got your Oriole trial, which showed 54 men, and there was a statistically significant lower progression rate at 6 months. Your Popstar had 33 men, and the local and distance recurrence-free survival was 93 and 39 at 2 years. The Ravens trial is ongoing. The Storm trial had 62 men with a median ADT-free 21 versus 13 months. Locate, this was not a study. It's actually looking at the role of imaging. The TROD had 74 men, both synchronous and metachronous, so de novo and oligorecurrent. And the 2-year progression-free survival was up to 72% when we treated them with radiotherapy. 63 men, median time to ADT was 20.1 in the OLI-P trial, and the PSA progression was up to 13 months. And then the more important, sort of interesting one is where we're using the lutetium PSMA, and this is by the Bullseye trial, which is still ongoing and we're still waiting for the results. For baseline is only offer metastatic directed therapy to M1 patients with clinical trial setting or well-designed prospective cohort studies. so it's not for everybody. Uh, this is an interesting article again that I came across, and it has two parts that I'd like to bring to. One is, what are the modes of progression after you've done metastasis-directed therapy? And the diagram on your right sort of shows two scenarios, one where there was ADT given, and the B is where there was no ADT given. And you can see the numbers don't change quite a bit. And after you've done your metastasis-directed therapy, you still have a good number of patients who could still be controlled, or 41% of patients would have long-term control. About 30 to 40% would have oligoprogression that you can retreat, and then only about 20 would have polyprogression after treatment. And this would be the problem where you would want to identify these patients early and probably start them on systemic therapy. The other sort of interesting idea that came from the patterns of recurrence was, for patients whose original site of metastasis was bone, the recurrence was again bone in about 86% of the patients. And for those who had nodal metastasis, the recurrence was again nodal metastasis in about 65. So is this again different diseases in different areas? Is it about the metastatic niche? Is it about the seed and soil theory? There's a lot to be asked. The idea of salvage lymph node dissection, and you would consider this one because the natural history of recurrent disease is favorable than the de novo disease, and the natural history of recurrence in the nodes is much more favorable when you have recurrence in the nodes than compared to bone or visceral metastasis. The current guidelines say that there's no high-level evidence for oncology value of salvage lymph node dissection. So we would generally not offer salvage lymph node dissection at the moment, but there are centers that do that, and there is quite some data coming up from that. The important part is that you would require reliable imaging, and the PSMA PET at the moment is a good, reliable sort of imaging, but at lower PSA rates, it still doesn't give you much. There is more studies being done where they're using lymphoangiographic studies. There's actually a gamma scanner that you can use intra-op and give the tracer, and you use that to check the modes, just like what you do for penile cancer when you're doing dynamic sentinel lymph node biopsy. So oligoprogressive metastatic prostate cancer, this is now in the setting of castrate-resistant prostate cancer. And you straight away with sort of non-metastatic prostate cancer, there are three trials that come to mind: the Spartan trial, the Prosper trial, and the Ramis trial, where the apalutamide, enzalutamide, and darolutamide were used. And they all showed overall survival benefit. But what was this based on? It was based on conventional imaging. And when you used functional imaging, 29% of these patients were actually oligometastatic. And could you therefore have any sort of benefit in giving systemic therapy earlier on in this subset of patients? This was another study where they sort of had 74 patients with non-metastatic prostate cancer on conventional imaging, underwent dual tracer and sort of PSMA PET and FDG PET, and the mean PSA of these patients was 0.59. They then received a metastasis-directed therapy for those that were diagnosed with less than 5 mets, and you can quite see the improvement in the overall survival of these patients. What about the oligoprogressive prostate cancer, castrate-resistant prostate cancer? This is a study from European Urology in 2021. 68 patients treated with metastasis-directed therapy, and metastasis-directed therapy can improve median time to PSA failure and time to the next intervention. So it helps with prolonging your second-line treatment in such patients. I'll briefly touch on systemic therapy. And this is, again, a whole new discussion that you can have. You can go on for an hour. And the ideas, and I picked this up from the EAU 2022, what would you tell your patients? Are we postponing ADT for at least a decade? Or should we have added systemic therapy to the patients? And also, it's important to know, what would your patients want in the end? Do they just want, no complaint survival, or would they want to live as long as possible? And that is important when we're starting to speak about prolonging life and trying to aim at cure. This is again from the EAU guidelines, and it's mainly sort of highlighting the role of adjuvant ADT in the patients with N1 disease after extended lymph node dissection, and what are your options for it. we're heading towards, and I like this diagram where you're talking about ADT, where it might be a better flow diagram. So if you've got PSA recurrence following radiotherapy, and you do a PSMA PET or a PET imaging of any sort, and it's negative, you can offer your patients observation or ADT. If it's a high volume disease, you offer ADT with added systemic therapy. But suppose there's PET positive limited nodal disease, then there's the idea of intermittent ADT. And when would you stop that? That's like when your PSA gets to less than 0.2, you hold your ADT, you keep testing your testosterone and your PSA. And once the PSA goes above 1 again, you re-image them and reclassify them. And the idea here is about the intermittent ADT, which helps with the side effects related with ADT and the quality of life improvement in these patients. So in a nutshell, this is a disease that is continuously changing. It's changing in its definitions, changing in its patient population, changing in imaging modalities, changing in radiation techniques, changing in surgical techniques, and there's better understanding of the disease process at the end. So there's a lot happening, and it's a very, very heterogeneous group of patients that we're talking about. But I hope I've done justice to the talk, and thank you for listening to me.
Just stop sharing. Yeah, yeah. Thanks a lot, Bhavin, for an excellent talk. Do we have questions on the floor? Because I mean, I think this topic needs a lot of discussions, I must say. Are there any questions on the floor? I think just one comment. I think, Bhavin, from what you've presented and your data, it does seem like, you know, in patients with low volume disease, oligomets, it has become the standard of care to treat the primary with ADT. The biggest question is, you know, there's lots of, you know, studies looking at ADT, I mean, in different settings, like you said, in the primary setting, oligorecurrent. I think the role of ADT, if you're treating a patient with oligometastatic disease, is not clear whether you give them short-term or long-term. If you can just explain to us, you know, what's the idea and how long should we give ADT? That's the first question, and I'll reserve the others that I have a lot, because I see Prof might have a question there. See, his screen is on.
Okay, no, thanks, Sam. From my reading, you're 100% right. The idea of ADT is still debatable. There's still a lot of studies that are waiting, but there is the one where patients are given continuous ADT up until death. And then there's the idea of intermittent ADT, and that was what I was trying to sort of allude to in my last slide, where they're trying to sort of develop flow diagrams for patients and how you'd work them up and which patients would be sort of candidates to get intermittent ADT, and at what stage would you stop intermittent ADT, or what stage would you want to restart ADT? Unfortunately, I don't have a hard, fast answer for you, but that's the best I can sort of come up with.
I can just ask a question, Sam. I don't know if you can hear me okay, but just to commend both speakers on exceptionally good talks. I think the level and depth of their talks and their quality of the presentation is a very high standard, so thank you. We've had good data, Bhavin, from Horrid and Stampede to suggest that radiotherapy and stereoscopic radiotherapy had a role for oligomets, but the data is lacking in surgery. There's been some grumbling that the trials that we had hoped would be done, quality level 1 trials, will probably never be done. Do you think that the data that you presented and the other observational trials are enough to offer our patients cytoreductive prostatectomy?
Cytoreductive prostatectomy. Yeah, so I think, Prof, I just sort of had spoken about that, and that was what was exciting for me, you know, in this sort of setting. It's actually this. I'm trying to just get to it quick. That's the one. So this is actually a randomized control study done in China, which had 200 men. And this is what there are still some more studies. When you go to check up on the system, there are quite a number of randomized control studies that are sort of in the pipeline and coming up. But it is getting interesting that you can actually offer radical prostatectomy in this cohort of patients. And again, I mentioned the trombone study, which was a feasibility study. They had very little patients. They had about 40-something patients, but they did show that radical prostatectomy was still an option in the patients in the M1B scenario in that case. So I think it's interesting and it's exciting that we actually might have a role to play in this subset of patients. I believe that in the next year or so, there must be good data coming out in terms of randomized control trials that would actually support this idea or logic behind it.
Thank you.
Yeah, Bhavin, sorry, I'm just gonna maybe ask you two more questions. It's a very interesting topic. I mean, the first I heard about this was 2017, and I see still there's a lot of work that's still being done on it. So the other thing is just a comment on the ADT. It does seem like for oligorecurrent disease, I think most studies are looking at giving MDT to try and prolong time for you to get to ADT or systemic therapy. So in the oligorecurrent sort of setting, I think there is enough data that, one can give short-term ADT or in fact delay ADT up until the guys get a PSA, a recurrence. That's the one comment on the ADT. And the second one, I wanted to ask you, it does seem like patients that have had a PSMA when they were staged, they seem to do better than patients who had conventional imaging. Do you perhaps know what the reason would be in this oligometastatic setting? Why do they do a bit better than guys who've got conventional imaging? The other question or comment I had was the China study that you had, which was quite compelling data on radical prostates, because we've been trying to do that, but we just don't even have enough data. So the question is, in the patients that have had radical prostate cytoreductive, as Prof calls it, so how many of those patients had ADT as their mets, and how many of those actually had bone mets as a form of metastasis? Because you mentioned they only got ADT, nothing they never got MDT, metastatic directed therapy. If they're just mainly patients with lymph nodes, it could be a different story if they had lymph nodes in the pelvis, as opposed to patients who had mets on the bones.
Which setting? So I think just answering about the oligorecurrent, from what I read in the setting that PSMA was better than conventional, it's the whole idea that you're picking up the disease earlier. But that's how I'd argue it, in that you can actually pick up metastasis much more earlier and stratify your patients better. Because by the time you're having conventional imaging showing up metastasis, I presume you'd have smaller metastases that would actually be picked up by the PSMA PET. And this then puts the patient in a different group and not the oligometastatic group. But if you're seeing the patients in oligometastatic, it's likely the conventional imaging is not picking up this. And therefore, if you do metastasis-directed therapy to this subgroup of patients, you'd actually end up having a better outcome, because you're breaking down the metastasis, the primary or local control, and you're breaking down the whole communication. And again, you're reducing from the 10-man study, you're reducing the idea of metastasis to metastasis. So I'd argue it like that. The patients from the China study did get ADT, and they were all given ADT at the start. And from what I remember from the study was that after initiation of ADT, my bit of gray on the timelines, but they gave them some time, I think about 2 to 3 months, and then they repeated imaging. And that's because in these patients, you have a T3 or T4 disease, and they might not be surgical resectable at the start, but once you've given them ADT and there's regression of the cancer tumor, there might be a better plane, and that's what they saw in the imaging, and that's what then they offered those patients radical prostatectomy. So ADT played a major role in these patients, and because they had bone metastasis, they were given sort of metastasis directed therapy as well. I'm just going to check in this. Would a radical prostatectomy in patients with M1AB not still required adjuvant RT? They would then be exposed to side effects of both. That's a good observation. I think that is what the radiotherapists would keep telling us, that you're going to bring your patients back to the oncology clinic anyways after doing a radical prostatectomy. But I guess in a very good chosen cohort of patients, and in patients who've got good planes, you're likely not going to end up requiring adjuvant RT at some point, or you're going to prolong the time to adjuvant RT and give them a better control. And that was what I was trying to allude to when I was discussing the role of surgery in this patient.
Yeah, no, thanks a lot. Yeah, so the other thing, we're chatting about recurrent and PSMA PET. I think Patel mentioned very well that the issue is that, I mean, if you're using a PSMA PET, you are going to pick up the real mets, but if you're using conventional, the guy might have double the mets, but like you were saying, you're treating the few that you're picking up on the PSMA PET, and it's a good thing because you're treating all of them than in conventional. And the other thing is that PSMA PET is able to pick up mets at very low PSAs, because the other endpoints in these patients were PSMA recurrence. So if I do a PSMA of 0.5, pick up a small tiny MET and do MDT on that, then obviously the PSMA recurrence is likely to take a bit longer than a patient who needed to have a PSMA of whatever, of 5, before they could have conventional imaging. Yeah, no, this is just a lot of discussions. Everything just comes in as we go along. Prof, there's a question from here.
Thank you, Sam. I wonder if I can just ask Mark a question. In order to understand the benefit of controlling the local disease, we need to understand the soil and seed theory of how it spreads, because it doesn't make much obvious sense to remove the primary if you've got metastatic disease. And yet the new work that I think he's been talking about can explain that a bit. Can Mark perhaps explain the seed and soil theory and how it relates to why prostatectomy in the M1 setting might help? Thank you, Mark.
Yes, Prof. So look, the seed and soil hypothesis, was in the 1800s already. It's quite an old hypothesis, and the newer ones, which was initially described by the gentleman that coined the term oligometastasis. They described their own hypothesis, and their hypothesis was based more on genomics. And now, if we look at that 10-man study that Dr. Patel and myself alluded to earlier, which was a study that they did on post-mortem patients, and they all had metastatic prostate cancer in the setting of castrate resistance. And when they, using this 10-man study, they did genomic sequencing on all the metastases. And they found that the metastases didn't necessarily come from the primary. They came from metastases to metastases. But as also that there was communication between the metastases and the primary. And not only that, the primary sent out little seeker cells, and those cells would create a niche in the bone or the lymph nodes or wherever that would set up, set a little command tent for the metastatic cells to then go and occupy earlier. So the idea is that if you treat the primary, you disrupt the communication, the lines of communication between the base and the front lines, between the different outposts of the front lines, and you disrupt the scouts that are going out to look for metastatic landing sites. So that's your little army analogy, I guess, to simplify the term, but it's disrupting communication, and that was now well described in this 10-man study, as well as newer rat and mice study.
Yeah, thanks a lot. Yeah, thanks a lot to everyone who joined. It doesn't look like there's any further questions. And yeah, thank you so much. We'll see you guys in the next week. Thanks a lot. Thanks to Great Talks to Bhavin and Mark.